My patient Kiran, wife of Atif, 38 years of age, done her formal education till matric, housewife, resident of Lahore, married for the last 19 years. It is first marriage of both partner. She is para 3 with 2 miscarriages. All are vaginal deliveries. Her last child born is 8 years old. Her last menstrual period is on 28 February 2018. Presented in outpatient department of Combined Military Hospital Lahore with the presenting complaint of postcoital bleeding from last 3 months, vaginal discharge from last 6 months. My patient achieved menarche at the age of 12 years. She was having regular cycle of 5 by 30 days with average flow. There is no pain during menstrual flow and coitus. There is no heavy menstrual bleeding, postcoital bleeding and intermenstrual bleeding. But now from the last 3 months she is having history of postcoital bleeding which is bright red in color. Initially it was spotting but now mild in amount, remain for 1 day, and she used to soak 1 pad only. It is after each act of coitus, and there is no history of heavy menstrual bleeding with colicky abdominal pain or intermenstrual bleeding. There is history of pain during coitus which is deep dyspareunia, mild to moderate in nature, remains for 1 day, relieved spontaneously, and patient was not taking any medication for it. Previously they were having coital frequency of 2 to 3 times per week, but now it has reduced to the extent that they did not have coitus from last 15 days. There is history of vaginal discharge from the last 6 months. It is yellowish in color, mild to moderate in amount, thick in consistency, associated with itching and foul smell. Off and on it is blood stain, but no association with coitus and menstrual cycle. She got married at the age of 19 years. It is first marriage of both partner and they are not using barrier method of contraception. There is no history of vaccination in the childhood, smoking, perineal lesion and multiple partner. There is no history of change in appetite and weight. History is not suggestive of any metastatic disease as there is no headache, blurring of vision, cough with expectorant containing blood, right upper quadrant pain, urinary and bowel symptoms. She has
all these symptoms which you have said, no symptoms of cough, headache, why are you specially mentioning these?
Sir,
what have their relationship to post-coital bleeding and vaginal discharge?
Sir, metastatic.
Cervical cancer, if at all we are thinking of cancer metastasis, does it metastasize to the brain so frequently that it causes headache and things like that? Very infrequent. Yeah. Okay, go on.
She has not consulted the doctor previously for this complaint and was not taking any medication. She presented for the first time in outpatient department. After admission, she was clinically assessed and her blood test, urine test, ultrasound was carried out. Pap smear done for the first time. Examination under anesthesia was carried out and biopsy was taken. MRI was done, but reports are being awaited. She is mother of 3 daughters. All are her.
We'll stop here because the rest of the history perhaps is not so relevant. So here is a patient who is 38 years of age.
Yes, sir.
And married for 19 years,
Yes, sir.
para 3, complains of postcoital bleeding and vaginal discharge. That's the main complaint.
Sir.
What do you think she has? What is your, from this short history, patient 38 years of age, married for 19 years, para 3, complains of postcoital bleeding for 3 months and vaginal discharge for 6 months. Vaginal discharge, you have described the features reasonably well. Its amount, its consistency, color, and association with menses. you have described. So whenever you have a patient complaining of discharge, you must ask all these questions which the lady has asked. Yeah, okay. What do you think are the possibilities in this patient?
Sir, any lesion in the vagina, cervix, or uterus?
I don't know what are those lesions. Name them.
Sir, any local pathology in the vagina or cervix, like polyp? Any?
Do you have vaginal polypi?
So you have cervical polyp.
So you started. Forget it. You are thinking in terms of causes starting from cervix. Okay. Cervical polyp. Okay. Anything else?
Sir, degenerative cervical fibroid.
Degenerated cervical fibroid.
And
Okay. That will come under the heading of cervical polyp.
sir,
Would it or would it not?
sir, polyp are 3 types in the cervix. It can be edematous, fibroidal polyp, and malignant.
So when you say fibroid polyp, it means same thing what you are saying as a second diagnosis, cervical fibroid.
Sir,
It would be nearly same thing.
sir,
Fibroid in the cervix, generally in the form of polyp. Okay, cervical polypi.
and malignant growth in the cervix. And
So
malignancy in the cervix.
CA cervix. Okay, that's two. One is polypi, second CA cervix. Anything else you think of in this patient? You know, when you have this kind of patient or any patient, make a brief history out of the long one, and then try to think of the differential diagnosis. Once you have made that short list of differential diagnosis, then you go back to your history. Related to that, have you asked all the questions? Or is any part of the history you have not explored further, which you should have? That would be possible only if we have a short list of differential diagnosis. After going through this brief history, 38-year-old, 19 years married, para 3, complains of 2 complaints, postcoital bleeding and vaginal discharge. So let's stop here. Make a habit to stop there, and then make a short list, not long list, indefinite. Go on and on, 30 causes, 40 causes. No, 4 or 5 common causes, maybe sometimes only 2 you can think of. Good enough. And once you have named those causes, then you go back to your detailed history and ensure that you ask all the questions related to those causes. Then your history will be complete. Sometimes it happens that you think of a cause and possibly you have not explored the history in detail. So you'll ask those questions. So the lady said causes in the cervix. 1, polyp, and 2, carcinoma. Anything else you can think of?
Sir, any endometrial polyp coming?
Endometrial polyp coming right through the cervix. Okay, endometrial polyp as well. Anything else? No?
Infections.
Let her finish. You will have, all of you will have a chance. And when you have a chance, you will fail. That I make sure. Okay, anything else? See, if you are thinking of a local cause, there has to be a local cause. There has to be a local cause, because that cause, whenever it is disturbed or hit mechanically during coitus, it bleeds. So there has to be a local cause. And the lady has gone up from cervix to endometrium. The local cause could be in the endometrium, the local cause could be in the cervix, local cause could be in the vagina. These are three areas. Now, in endometrium, we are stretching it a little too far. There's endometrial polyp which is projecting through the cervix. Possibility. But once you think of endometrial polyp, then ensure that you know all the four causes of endometrial polypi, or four types of endometrial polypi. Because the examiner is bound to ask you, if it is endometrial polyp, what type? So prepare yourself for that. That you know, and there are four endometrial polypi, three cervical polypi. So if you name cervical polyp, make sure you know the names of those three cervical polypi. Otherwise, don't mention it, because if you do and don't know the causes, don't know the differential diagnosis, then it's not good for you. Not good for you. For example, in this particular patient, if we don't mention endometrial polypi is the differential diagnosis, because it's a far-fetched thing. Maybe examiner will never ask you about that. And if you don't know all four, it doesn't matter. But you ask for the trouble yourself, endometrial polypi. The examiner will stop you. Tell me what are different types of endometrial polypi. If you name them in 5 seconds, you're all right. If you don't, you'll waste 2 or 3 minutes of your precious time. So one differential endometrial, we'll come back to the types. So endometrial polypi to cervical polypi. The lady has mentioned these two names. I haven't. So if you say cervical polypi, she named them. I think she has named them. And three types of cervical polypi. And anything else in cervix? Other than polyp, you said carcinoma, cancer cervix. So I would say, I said that when I said cervical polypi, because carcinoma of the cervix can be polypoidal, can be ulcerative. So in that, perhaps we have covered CA cervix. But in the cervix, other than polyp, there are other lesions as well. There are other lesions as well. Commonest lesion in the cervix? Ectopy. 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 Did you think of ectopy?
Sir.
Yeah, did. What is ectopy?
Sir, it is the...
You must know that as well. Whenever you say name any differential diagnosis, you must know the details of that. So, Bismillah. If her mother was sitting there, she would say this. So, ectopy. If you say ectopy, then you must know very briefly what ectopy is and maybe what's its treatment. Because that's how you are asked questions in the exam. You name any pathology, examiner says, yes, tell me details of that pathology, and then because it's a clinical examination, and what's the treatment of that. So you must know very briefly if you're mentioning those causes. Okay, ectopy. What is ectopy?
So when the squamocolumnar junction moves out due to the hormonal changes in reproductive age.
Don't have to say due to hormonal changes. We don't know what is the cause of ectopy. When squamocolumnar junction moves out of external os to cover ectocervix, then cervical canal is covered by columnar epithelium. Ectocervix is covered by stratified squamous epithelium. Columnar epithelium always looks red. Stratified squamous epithelium looks pink. I think I mentioned this last class as well. So the ectocervix, which normally is pink, then it starts looking red, like endocervix. And stratified squamous epithelium is in multiple layers, like skin. And it is resistant to any trauma. Whereas columnar epithelium is vulnerable to trauma because it is single layer epithelium. So if there is ectopy, there is a possibility that columnar epithelium, which is covering ectopy, whenever it is traumatized, it may bleed. That's how it is. Okay. Then after CA cervix, we come to ectopy. Anything else? No. Well, we could add here maybe chronic cervicitis, chronic infection. Whenever there is infection, there is inflammatory reaction. And that inflammatory reaction makes the tissue fragile. Okay, after cervix, you didn't mention, but I added to your list, cause could be in the vagina. What could be that cause? In the vagina. What this patient?
Infection.
What do you call it?
Vaginitis.
Infection of vagina, what do we call?
Chronic vaginitis.
Don't have to say chronic. Vaginitis. Infection of vagina is vaginitis. So the cause could be vaginitis. Right? Okay. Anything else in vagina? Last time I told you there are no glands in vagina. So, but there can be carcinoma of vagina, which is extremely rare. So, if you pushed, what more, what else? You can say extremely uncommon carcinoma of the vagina. And of course, there could be trauma to vagina, which can be common factor, particularly if husband was away for a long time and then coitus. Or not in this patient, postmenopausal patient, atrophy of the vagina, thin vagina, coitus. So now we go over our list again. For your satisfaction, I will not include that in my list, but endometrial polypi are: number 1, adenomatous polyp; number 2, fibroid polyp or polypoidal fibroid; number 3 is endometrial carcinoma. Endometrial carcinoma could be polypoidal and or ulcerative or spreading. In addition to these 3,
Placental.
Very good, mashallah. A placental polyp. These are 4 endometrial polypi. There is no placental polyp in the cervix first 3 years. In the cervix, adenomatous polyp, fibroid polyp, and malignant polyp, carcinomatous polyp, or polypoidal carcinoma. Right? So now we have a very brief list of postcoital bleeding that is either in the cervix or in the vagina. In the cervix, in reverse order, it could be vaginitis, it could be trauma, very, very rare, it could be carcinoma. And in the cervix, either a polyp or chronic cervicitis or ectopy. So this is the differential diagnosis of this patient. Right? Now, any question related to these we would like to ask? First, in the cervix, no special question except any past history of vaginal discharge or infection in the vagina or the treatment she had taken. As far as fibroid, any history of men, because it's unusual that there will be fibroid polyp only in the cervix, not because fibroid is generally a multiple fibroid disease. If there were fibroid upstairs in the body, they would be causing some menorrhagia or some heavy menstruation or some problem. So we'll ask questions about menstrual loss. And if it is a fibroid polyp which is in the cavity projecting out any colicky pain during menstruation, because a polyp in the uterine cavity is a foreign body. Whenever there is a foreign body in the uterus tries to expel it by colicky uterine contractions. And those colicky contractions are more prominent during menstruation. Then we come to cervix, same questions. We have not missed, the lady has not missed anything. But when it comes to vaginal discharge, usually vaginal discharge is recurrent. So past history of any attacks of such discharge, if they were, how were they treated or what was the diagnosis? After finishing this list, history of trauma, in this patient, husband lives with her, unlikely that it is coital trauma. It will be a cause if the husband was working in Dubai and coming home after a year or so. Then you can ask, was husband away before this coital bleeding started? Now, out of this, prepare yourself. If there is a patient like this, the discussion will be mostly, out of half an hour, 20 minutes, the discussion will be about CA cervix. Prepare yourself for that. If the discussion is going to be about carcinoma of cervix, now you prepare another list, second list. Causes of CA cervix are predisposing factors, then stages of CA cervix, and treatment. If you are doing well, you have finished all these CA cervix related questions in less than 20 minutes, say in 15 minutes. You have 5 minutes spare left with you. Then prepare yourself. You will be asked about pap smear and CIN, carcinoma in situ. You know, I just leave you with these thoughts. In reverse order, all of you know CIN, carcinoma in situ. All of you know pap smear. And then treatment of CA cervix and stages, everything, all of you know it. That's the trouble of the whole situation. You know it, but still you fail. After all, if there are 20 girls appearing in the examination, out of those only 4 or 5 pass. Other 15, they knew all this, but still they failed. They failed, number one, because they had not quickly revised these topics before the examiner arrived. For them, it came like a surprise. Asking about pap smear, asking about various carcinoma in situ stages, and then maybe you had thought of CA cervix, that was okay, but this part you were not prepared. When you were not prepared, all of you, all of us as a matter of fact, get nervous if suddenly you're asked a question. If you ask suddenly, how old is your husband? Because in Pakistan we don't wish each other happy birthday. How many of you wish happy birthday to your husband early in the morning? 2 hands, 3 hands. All the hands should be up. Why not? It's a good news, makes other person happy. Other person is your husband. As a matter of fact, you should know birthday of all your colleagues working with you. It sounds very good if somebody calls you in the morning, happy birthday. Then you tell your husband or wife, you don't remember, he remembers. He'll feel jealous. And so, suddenly if you're asked anything, other day I was asked, what is your blood group? I said, I've forgotten. Do you forget blood group? You don't. Because for years I never thought of my blood group. And because I never needed it. But here a question was asked. You were asking me what happened last Saturday. So during that investigation part, and I said, I don't know. My doctor laughed. Sir, how come you don't know? I said, yeah, I've forgotten this. So anything which you are asked suddenly, unprepared, unexpected, that puts you in trouble. So today's question, if you have a patient who has local complaints, these are local complaints, postcoital bleeding and vaginal discharge. And if for any reason diagnosis of CA cervix is one of the differential diagnoses, first you should have a complete list of differential diagnoses, not only CA cervix. And then briefly what are the symptoms, what are the causes and treatment of all of them, very briefly. But you will be asked in detail, CA cervix. So prepare yourself, causes, investigation, treatment of CA cervix. These days CA cervix is very easy from examination point of view. From examination point of view. Because surgery is indicated only in stage 1, that too early stage 1. Rest is all radiotherapy. All radiotherapy. So you should know how radiotherapy is given, or any medical treatment, whatever is given. So focus on that. But then coming to vaginitis, the lady asked all the questions. But remember to ask all those questions for vaginal discharge. Its onset, especially related to coitus, and then its relationship to menses, worse before bleeding, worse after bleeding. Then when there's more estrogen effect, then it's more likely candidiasis. When there's less estrogen effect, then it's likely to be trichomonas. Very simple. And its onset, then its amount, its color, its smell, and any irritation or pruritus associated with that. And don't forget any past treatment. You have to ask these questions. So, in this patient, have you had her physical examination? Oh, let's have that, so that we are more focused on to what the cause is out of this list of causes. But when you made the list, then go back to history. For example, stretching the thing, we said chronic cervicitis. In chronic cervicitis, it could be tuberculosis. It could be tuberculosis infection. And if it is tuberculosis infection, then lady's history about cough becomes relevant, because pulmonary tuberculosis precedes infection in other parts of the body. Generally, it's pulmonary infection, then spread to other organs. Rarely it starts from intestines and there's bovine type and reaches genital tract. So relevant to ask any past history of cough with expectoration or any treatment. That will become relevant like that. Okay, when you examined her, what happened?
So on local examination, vulva, vagina, urethra and anus are healthy looking with normal hair distribution, no discharge or bleeding coming out of introitus. On speculum examination, all the visible vaginal walls are healthy looking with normal rugosity. Minimum yellowish thick foul smelly discharge in the posterior fornix. Cervix is multiparous. There is a lesion of 3 into 3 centimeter on the posterior lip, spindle shape, irregular, everted margins, shallow base, containing yellow necrotic tissue and it's bleeding to touch. Posterior lip of the cervix was flushed with vagina. No discharge or bleeding coming out of the cervix. On bimanual examination, cervix was firm, uterus was 6 to 8 week size, anteverted, mobile, tender. Both the lateral fornices were clear, and after examination, my gloves were blood stained. And I would.
Very, very good. Very, very good. MashaAllah, MashaAllah. Where were you trained?
Last time I told you from multiple places.
Multiple teachers. So, last time she was sitting there and I asked her, Army, multiple teachers. And it's a big, big advantage to have multiple supervisors or multiple teachers. Generally in Pakistan, it's a negative thing, it's a tragedy. You're trained only by one person. There is no rotation. So you become photocopy of your supervisor. And by inbreeding, whatever your teacher knows, he teaches you. But the direct transfer means 10% less. So that's the problem about inbreeding. With inbreeding, the students are less trained than the teacher. You're going backwards. If you're trained by 5 teachers, you pick up best from here, and nobody is perfect. No professor is perfect. So he or she must have some good skills, good knowledge. You pick up that, and then you go to the next. Some from there, some from there. So you will turn out to be a better generation. Next generation will be better. And why the world today is better than yesterday? It is because your pupils, your students should be 10% better, not worse. That can be ensured by multiple teachers, multiple rotation. Although College of Physician Surgeons says there should be rotation, but somehow it doesn't happen. Now, here's a model who was trained, and I honestly feel this is the best pelvic examination I've heard in this classroom to date. I can compliment you like that. Like that.
Thank you.
So make a note how she described. Let's have it again. Yeah.
On local examination, vulva, vagina, urethra, and anus are healthy.
Instead of saying urethra, say external urethral meatus. Very rarely there's a caruncle at the external urethral meatus which could cause postcoital bleeding. I mean, that is a rare thing, that's why I didn't bring it in, but when you describe, say external urethral meatus.
Vulva, vagina, external urethral meatus, and anus are healthy looking with normal hair distribution. No discharge or bleeding coming out of introitus. On speculum examination.
Just a minute. So, before you put your fingers or speculum in, this is a must. You must tell or note. Even in your practice, it's not examination necessarily. Note any discharge present at the introitus. And if it is present, that is most important thing to describe. Blood-stained discharge, greenish discharge, whitish discharge, amount of discharge. But here the lady has noticed that there is no discharge present at the introitus. Next.
On speculum examination, all the visible vaginal walls are...
I would say add which speculum. on Cusco's Speculum Examination. It adds to your credit. Everybody will say on Speculum Examination without naming it. But when you name it, you're more focused, more specific. So you get extra credit.
All the visible vaginal walls are healthy looking with normal rugosity. Minimal yellowish.
Now, as we are discussing that, so on Cusco Speculum Examination, you will say the lateral vaginal walls are healthy or whatever. But if you have said, I'll use sim speculum, then you can see lateral as well as anterior vaginal wall. You will name it. This being one up over your colleagues, that's how you pass. Normally, routinely, you never say, I'll use this speculum. You take it for granted, this is Cusco's. So you don't name it. But if you name it, it's a plus point for you. So on Cusco's Speculum Examination, to be more hitting the nail perfect in dorsal position, I will use Cusco's Speculum Examination, and during that I noticed that lateral vaginal walls were healthy. Good. And again say on Speculum Examination.
On Cusco's in dorsal position, on Cusco's Speculum Examination, all the visible lateral vaginal walls are healthy looking with normal rugosity.
Good. Very good.
Minimal yellowish, thick, foul-smelly discharge was present in the posterior fornix. Cervix is multiparous. There is a lesion of 3 into 3 centimeter approximately on the posterior lip, spindle shape, irregular, everted margins, shallow base containing yellow necrotic tissue, and it's bleeding to touch.
Just a minute. Have you appeared in FCPS already? What a time. Never mind. We have been running this course for many, many years. Practically, I've been retired 20 years. For 20 years, I've been running this course. And so you can imagine a number of candidates who passed through this course and possibly passed FCPS as well. One of them is Dr. Aruba, who is the chief organizer of this. She was excellent. She was so good, I refused to ask her any question because she would always come out correct. So whenever she tried to answer, I said, no, not you, anybody else. And so she went and failed. I was very, very upset. Such a good candidate, because examination is also a chance. Maybe you're asked questions which you know, so you pass. Maybe you're asked a question which brings you down, you were not prepared for it, or things like that. So and next time she passed with flying colors kind of thing. So if you, next time, inshallah, you'll pass. Make a phone call to me, sir, you were correct. And you know why I'm saying, the first I said speculum, which speculum, and second, the description of that ulcer is perfect. Whenever you see an ulcer anywhere in the body, on the skin, on any part of the body, you must describe the way this lady has described. Number one, site. Number two, shape. You have described all that. Number two, shape. Number three, size. Site, size, shape, then margins. then base covered by purulent discharge or granulation tissue or whatever. And the only part which she has missed may be then surrounding areas. Usually they are edematous in malignant condition because cancer is spreading into the surrounding areas. And finally, bleeds to touch or not. Excellent. So she described that ulcer beautifully. Okay. And in case of local pathology, we had no ulcer other than ulcer. We're thinking whether this could be malignant ulcer. If it is malignant ulcer at the cervix, see a cervix. For that, by manual examination, you want to make sure whether it has spread into the parametrium. She said, uterus is mobile, fornices are clear. That's how she described. Very good. And last was the
posterior lip of the cervix was flushed with vagina, no discharge or bleeding coming out of the cervical os.
Very good. So now because we are left with only 10 minutes, let's presume that this, we suspect it is, all the description fits into CA cervix, I would say. There is a malignant ulcer. And I missed something which we should have discussed earlier. In causes, this patient never had vaccination against HPV. This should be added.
I told in the history.
You just said vaccination.
No vaccination in the child.
HPV was not mentioned. Because normally vaccination is that MMR. MMR is meningococcal infection, mumps, and rubella. That's the normal vaccination. Previously, it used to be BCG as well, against tuberculosis or against smallpox. HPV is relatively new, so you have to be specifically saying that this patient had, because I'm sure all of you never had HPV vaccination, because when vaccination came in, you were married. The HPV vaccination has to be given before first coitus, or at least under 20. Were you 20 when HPV vaccination came? None of you. You're approaching menopause. Wow. Only 20, 30 years left. So, we are talking about CA cervix. No? So, to tell the examiner, you are aware of this vaccination. You are aware of this vaccination. So, say that in the history, no HPV vaccination. Okay. Now, here's a patient. We have taken the history. She's 38 years of age. Para 3, and we have got diagnosed an ulcer on the posterior lip, which is actually flushed with vagina. It means possibly that ulcer is invading the posterior fornix. So these are physical findings. Now what will you do next?
Sir, after completing my all investigations, then I will counsel the patient regarding my diagnosis. And I will tell her that the definitive diagnosis will be made on histopathology.
Oh, very good. Now I know why you failed. In spite of such good training, you're jumping.
Sir.
This patient, you have made a diagnosis of CA cervix on physical findings, no way. No way. It is an important tip of the day that on physical examination you don't make a definitive diagnosis. Yesterday when Aruba told me this was the patient, I narrated to her a story when, about 40, 50 years ago, when I was working in Services Hospital. A doctor from Sheikhupura brought his sister to me, young lady, about same age, 28, 30, and I examined her. The appearance was of typical CA cervix. Very shocking, 28, 30-year-old CA cervix. So I was sure it was CA cervix, ulcerative growth and all that. We took a biopsy. It came back tuberculosis. Tuberculosis infection, particular ulcerative type, looks like CA cervix. This patient is also relatively young, 38. 38 is earlier than peak age of CA cervix. Peak age of CA cervix is 45 to 55. Peak age for endometrial carcinoma is 55 to 65. So this is earlier than 45. And same, I made a clinical diagnosis, CA cervix. Biopsy came out tuberculosis. We put her on anti-tuberculosis treatment. Believe it, after 9 months, the cervix looked perfect as if there was never any lesion. If I had informed the family or the patient that she has CA cervix, she would have been totally devastated. Anybody, you say you have cancer, immediately they start counting days, time, what's going to happen. So you don't say. You will say, I'll counsel my patient that you have a lesion at the neck of the womb which requires further investigations. Full stop. Which is true and factual. Same, a patient comes to you with large mass abdomen. You don't say that you have carcinoma of the ovary. You tell her that is saying there is some growth in your abdomen which needs further investigations. Full stop. You don't say it's fibroid, you don't say it's ovarian cyst, you don't say whatever other than gynecological causes could be for that mass. So your terminology has to, you must have said something like this, that's why the examiner took exception and paid you in spite of your good performance. And so in this patient, I'm glad we have discussed this component with you. After examination, I'll counsel my patient that there is some lesion or ulcer, if you like, and in our language, zakham keh dijiye, kuch keh dijiye. And you got a lesion at the neck of the womb which requires further investigation, which is true. Which is true. Okay. What will be specific, focused investigation for this patient? You will go through. Other than, you said, routine investigation and things like that.
Sir, specific pap smear, biopsy, examination.
Just a minute.
Examination under anesthesia and
जी उनको दें हाँ
the examination under anesthesia and biopsy of the lesion.
Oh, when she said biopsy, it kind of covers, but you're right, better said EUA
And also for rectal examination is done.
and
For rectal examination.
and rectal examination. Good, very good. That should be added to after you had this kind of lesion which is extending into posterior fornix. You should have added there that I'll do rectal examination as well. A PR per rectal digitally or by proctoscopy, then to find out whether that lesion is from the rectum coming to the posterior fornix. It could be reverse. Instead of cervix going there, it could be rectal coming into the posterior fornix and reaching the cervix as well. So that examination should be added. So I'll counsel my patient that she needs further investigations, and first thing is rectal examination. Second, you said I'll take pap smear. Remember, if there's a lot of necrotic tissue, pap smear becomes negative. So pap smear in a clinically visible malignancy is not useful. It is not useful because pap smear is cytology, examination of cells. If cells are killed, necrosis is killing of cells, are dead, then shape, nucleus, cytoplasm, everything is gone. So in this patient, pap smear is, when you have said it is covered by necrotic tissue, pap smear is, you say this, in this patient I will not take pap smear because of lot of necrotic tissue present there. You will get extra mark for that. Right? So we'll sideline pap smear in this patient. However, you will say to make a definitive diagnosis, she needs biopsy, which should be done under anesthesia, and at the same time, you will avail the opportunity of evaluating if it is cancer spread of the disease to stage 2, 3, 4, jo bhi ho. Right? So full statement will be, in this case, I will not take pap smear because of necrosis. However, to make a definitive diagnosis, I'll do EUA and biopsy of the cervix. To add to your credit, you will name even the type of biopsy you will take. I'll take a wedge biopsy from the margin. I'll take excision biopsy. Whatever type of biopsy you will take. Right? Now, for a very brief period, we presume, in this patient, we presume that in this patient, on speculum examination, cervix looks healthy. Same patient, I have said we deviate, which is a possibility. A patient comes to you with post-coital bleeding and vaginal discharge. You examine that patient, cervix looks healthy. Isn't it? As a matter, that's a more common thing. To have a lesion is definitely guiding you in one direction, but normally there is no lesion, or at the most ectopy. And so in such a patient, your line is correct then. First, I'll take a pap smear. Wait for its report. Then you go over, this is a patient where cervix looked healthy. Then you go over the report of pap smear. Class 1, class 2, class 3, class 4. Then apply that knowledge to further management of this patient. Then here cytology is very important. Well, I'll take a pap smear, wait for the report. Depending upon the report, in your book it's all written class 1 normal, class 2 inflammatory, class 3 substantial cell scene, 4 definite malignant cell scene. So our management will be according to the report of, we need not rush into biopsy then. We'll do biopsy only in this case where cervix looks healthy, it is stage class 3 and 4. We'll do colposcopy. We'll do colposcopy and colposcopic directed biopsy. Now you reach biopsy through this route. I have split the patient into 2 types now, 2 possibilities. One possibility, you have visible lesion. Whether it's polyp, whether it's ulcer or anything. If it is a polyp, we'll, after ultrasound and things like that, find out there's no other lesion in the uterine cavity. We'll do polypectomy, possibly histoscopy, and send that polyp for biopsy, histopathology. But most likely, that's why I've inserted that possibility into this discussion. Most likely, the cervix will look healthy in the examination. There you can't take the patient directly to biopsy. There, if you do that, you'll fail. There, first step is pap smear. Second, according to 1, 2, 3, 4. 1, do nothing. Routine, repeat after 3 years. 2, inflammatory, treat, repeat after 3 months. Class 3 and 4, I'll do colposcopy and colposcopic directed biopsy, acetowhite areas and things like that. Then you'll bring those in. And then whatever the biopsy is, let's say, now come back to our patient, that if it is CA cervix, number 1, I'll stage the disease. Number 1, I'll stage the disease. All of you, CA cervix, if you have not read up till now, I'll be very surprised. You must have read 10 times. And CA cervix, if it is stage 1, how to stage and then stage. If it is stage 1, limited to cervix, then there are 2 possibilities. either radical hysterectomy, what is called Vardaim hysterectomy, or straight away radiotherapy. Both have similar results. So in your case, in the examination, you say, I do not have sufficient experience of Vardaim hysterectomy. Raise hands those who have done 10 abdominal hysterectomies. Only one. See, what a tragedy. If you haven't done abdominal hysterectomy, how are you going to do Vardaim hysterectomy? So your training is deficient. Never mind, make it up after passing. And so stage 1 can be treated by Vardaim hysterectomy or radiotherapy. And stage 2, 3, 4, all of them these days need radiotherapy or chemotherapy or both. I don't know the details. Read the details further. So I summarize 2-3 things which have come out in this morning discussion. Number 1, immediately after presenting complaints, you'll stop, make a short list of differential diagnosis, and incorporate questions about that differential diagnosis into your history. If you go through the history like this, still you come back, make a differential diagnosis. If any questions left, fill in the gaps. In today's question, possibly CA cervix, the causes, we go home and read causes. Smoking, alcohol, anything which suppresses immunity. They are all causes of CA cervix as well, or malignancy anywhere. So she has not asked whether she smokes or not. Alcohol in our country, possibly not. But smoking, yes.
Sir, I asked.
You ask?
It is
So you will ask those questions. And then causes in the endometrium, in the cervix, in the vagina. Be prepared for questions related to all those diseases. Then pelvic examination, perfect. MashaAllah. Nazre Baddur. And then we make, in today's case, we split hypothetically. Cervix looks healthy, what shall we do? Which will be usual case in examination. They'll do pap smear, they'll do colposcopy, they need be, and all that. And colposcopic direct biopsy. But in the present case, because the ulcer is so visible, description of ulcer, adopt that, what she has said. And then, if it is diagnosed as CA cervix, possibility is spreading into the posterior fornix, into the vagina, then it means it's beyond stage 1. In this case, we will not do surgery, we will refer her for radiochemotherapy. Hello. Bas.
Sir.
Thank you. Very good.
Thank you, sir. Sir, surprisingly, when we did the MRI and MRI report came after, she was having posterior cervical degenerative fibroid.
चलो फिर अल्सर कहाँ से आ गया?
सर था, it was there, ulcerating, foul smelly growth was there.
ना, देखे ना, वो degenerated fibroid अपनी जगह पे, लेकिन आपने जिस तरह अल्सर डिस्क्राइब किया,
It was there.
और नहीं, इसका मतलब डबल पैथोलॉजी होगी। इसका मतलब आप कह रहे हैं डबल पैथोलॉजी इम्तिहान में बहुत कम होती है,